Today we're talking about the intersection of lifestyle and sleep medicine with Dr. Michelle Jonelis. She is a board-certified sleep medicine physician and lifestyle medicine doctor. She has a private practice in the San Francisco Bay Area, and she is an expert in all things sleep and lifestyle. So I'm really excited to have this conversation today. If you're a physician who wants to up-level your sleep medicine knowledge, then go ahead and subscribe to this channel. This YouTube channel is for you, the physician, the clinician who wants to learn more about clinical sleep medicine, because most of us don't get that much training in clinical sleep, but all of our patients have to sleep. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine. Every video is eligible for CME credits, so watch all the way to the end and then grab your CME credit. The link is in the video description underneath. And then if you'd like to learn more, grab my free sleep mini course at intrabalance.com/doctors. It's filled with lots of great sleep medicine pearls you can use in your clinical practice today. All right, well, Michelle, thank you so much for coming and to my home and joining me here today. It's really fun to meet in person. We were talking about how we're so used to doing everything online these days, and it's almost like a novelty to meet face to face. So I'm really glad that we were able to do this.
Thank you. Yeah, no, it's great. My practice actually, when I started it, I thought it was going to be all Zoom, because what I was doing, I was in private practice before I started my own practice, and since the pandemic, right, everything has been on Zoom, and even when we went back to in-person, a lot of patients still wanted to see me over Zoom. That was most patients. Even I was in Redwood City. Sometimes the patient would be in Redwood City, and they would still see me over Zoom. So I just assumed that when I opened my practice here in Marin County, it would be the same. But actually, I've been surprised that everybody wants in person. And so then I had to find an office space, and now I rent an office space by the hour because I'm just starting up. I don't want to pay for full time, but most of the patients actually want to be seen in person. And I got an office space that has big windows like this and a nice view, and it's really interesting. I feel like everybody is getting better faster just because coming into the office space is this very therapeutic environment, right? Like even if they were in a bad mood, you're looking out at the marsh. I always position them so they have the better view, and it's bright, and it's just, I don't know, I think it's very powerful. So I think we've forgotten how important in-person interaction is.
Yeah, absolutely. And I think there is that therapeutic aspect, and especially from lifestyle sleep perspective that we're going to talk about, of just activation, of getting up, getting out of the house, getting fresh air, sunlight, talking to people. And that's something we often miss when it comes to helping patients with their sleep. So I know you're an expert in that area, so we're going to talk more about that. Maybe we can start by just hearing more about how you got interested in sleep medicine, and what was your journey like? I think sleep is one of these things that as physicians we don't get a lot of exposure to, and many of us don't think about sleep as a specialty. At least when I was in training, when I got interested in sleep, my attendings were like, what? Like, why? What is that even? Is that a thing? So how did you come about, your interest in sleep and becoming a board-certified sleep doctor?
Yeah, great question. Thank you. So I always struggled with sleep, actually, growing up in my family. My mom and my brother were good sleepers, and my dad and I were bad sleepers. And I, struggled with insomnia, at times difficulty falling asleep. Sometimes I would get my mom, I can't sleep. She'd come try progressive muscle relaxation with me, all this stuff, which did not work at all. She would fall asleep and I would not. And then it wasn't severe, but I struggled with that. And then in college, my dad actually read Bill Dement's book, The Promise of Sleep, and he told me about it. I never read the book, admittedly, but he told me about it and told me, how important sleep was. And in college, the insomnia symptoms more, resolved, and it was more like difficulty falling asleep and typical more delayed sleep phase stuff, insufficient sleep. But I started really prioritizing sleep and actually figured out after we had this discussion about the book that if I slept, I would, rather than studying on a test, I would actually do better. Like if I didn't study at all and I just went to sleep, I would do better on the test than if I stayed up studying. And so it was this big revelation. And then of course I signed up for Bill Dement's class at Stanford, which was happening at that time. What was it called? Sleep and Dreams. And that was interesting. His goal was really just to teach people that it was driving while drowsy was dangerous. He gave that message every single visit. It is a very important message still, but the class was interesting. And then I I don't know, I continued to think about sleep. I continued to experiment with my own sleep. And then when I went to medical school, I wanted to do a year of research, right? Take a break. My husband and I were living apart at the time, or he was my boyfriend at the time. I wanted to spend a year with him. And I went to this talk where they were saying how to choose a research topic. Choose something you're interested in, right? Think of something you're really interested in and find a topic that that applies to. And I said, well, I'm interested in sleep, and in medical training, there's a lot of sleep deprivation, right? Like, what's the deal with the sleep deprivation? I've heard it's bad. Can I do research on sleep deprivation? And so, Google search, found a sleep laboratory and emailed them. Can I come do a year of research on sleep deprivation? Sure, come on down. My husband was in San Diego at the time, so I went down there and was fortunate enough to work with a fantastic sleep researcher named Sean Drummond, who just sort of taught me, he taught me about cognitive behavioral therapy for insomnia. He taught me about nightmare treatments. Of course, we did all our sleep deprivation projects. The lab was super collaborative. Everybody took shifts keeping the research subjects up at night because it was a sleep deprivation lab, right? So you had to keep these people awake so they would be sleep deprived. And it was just a lot of fun. I loved it. And after that year, I thought, maybe I could do this as a job, right? It's really, really interesting. And then I decided I wanted to specialize in neurology and considered some other subspecialties in neurology, but ultimately came back to sleep. It's just such a cool area. And as I learned more about sleep deprivation and more about insomnia and insomnia treatment, I was sort of able to improve my own sleep, resolve the insomnia issues that I'd had previously, and really just kind of gain this better understanding of my own sleep and how sleep works. And the great thing about sleep is you can do personal experimentation, right? Like you can try different things, and then you can have family try different things and friends, and you can kind of get all of this information just from a personal experimentation standpoint.
Right, absolutely. And because it's something all of us have to do, right?
Right, we all sleep.
Yes.
Exactly. And so I was fortunate enough to do my fellowship at Stanford, which is there are 8 fellows per year. And when I did it, they do a really great job choosing the fellows. And so I was paired, with these 7 colleagues for the year who were just amazing people, amazing sleep clinicians, very inspiring. And in that year, I also had the opportunity to learn cognitive behavioral therapy for insomnia with a real psychologist, Rachel Mamber, who's also really fantastic, and another woman named Allison Seaburn, who was also amazing. And so I was able to do special, not all of the fellows got to do it. I was actually the only one who was able to complete the whole training my year, but I got this specialized training in cognitive behavioral therapy for insomnia, and then I realized, it was this revelation where I was able to fix a patient's sleep without prescribing anything. And I remember the very first patient I saw was this woman who had insomnia. I think it had been like 20 years. She was in her 50s. She'd had a rape, unfortunately. That was the cause. That was what the insomnia dated back to. I was terrified when I went into the room with her because I'd never seen anybody like that. I thought, there's no way that this woman's going to get better. And literally the second session, her sleep was fixed. And it wasn't me, I just said whatever the psychologist told me to say, right? I didn't know what I was doing at that time, but I asked them what I should say. They told me what to say. I said it, and she was better. And it was this amazing thing. And after that, I was hooked, and I thought, this is, the greatest thing in the world, to be able to help somebody sleep better just with your words, right? And giving them advice about sleep. And that became the focus of the rest of my fellowship. People would want to prescribe sleeping medications. I'd say, let's do cognitive behavioral therapy for insomnia. And then when I went into my private practice, I was super lucky that I'm not a mental health professional. I'm just considered a regular physician because of my neurology training. And so basically I could do cognitive behavioral therapy with every single patient that came into my office without having to get special approval as a mental health provider. I could just bill it as a regular medical visit. So I sort of had this superpower. I could take Medicare, I could take all insurances, and I could just work with them. I'd say, hey, we're just going to work on your sleep. And I could just right there, the next visit, start doing cognitive behavioral therapy for insomnia with them, and then circadian manipulations and all of this stuff, and really figure out, again, do more experimentation. And at first I just started with the easiest, most simplest patients, right? Whoever I felt comfortable with, I sent everybody else to other providers. But little by little, as I got more comfortable, I expanded my comfort zone to the point where at the end of my practice, there's basically there are no patients that I would not try cognitive behavioral therapy for insomnia with. Even at the worst possible outcome would be that I basically stabilize them on their medications. I can't get them off, but I stabilize them and they feel more confident about their sleep. And the best possible outcome, of course, is their insomnia is fixed, they're off their medications, all of that. Yeah.
It's such a powerful thing, right? As you said, just be able to use your words to help someone heal.
Yeah.
Really, that's ultimately what we're doing. We may not be curing whatever was going on, like with your patient who had PTSD,
right,
but we can help them heal in a very deep way.
Yeah.
And I think oftentimes sleep can feel very hopeless for patients. And even for physicians. I see this a lot in physician Facebook groups or with colleagues. They kind of throw their hands up and I don't know what to do with this patient, and their Ambien isn't working, or we keep increasing their trazodone and they still can't sleep. And there's some very simple things, methods from cognitive behavioral therapy for insomnia that even they can use, even if you're not trained in it.
Yeah.
I'm curious, what would you recommend to a clinician who is struggling with patients like this, who are going through med after med after med and it's not working? What can other clinicians start implementing?
I know. So, if finding a provider who specializes in cognitive behavioral therapy for insomnia in your area, I think is a great step. There's databases online that you can access, and you just find somebody in your area. The problem is that insurance reimbursement is low currently. As my new practice, I don't take insurance anymore because as I spent longer and longer with patients, added in lifestyle medicine, it just became a losing battle. My reimbursement could be, $30 literally for a patient who I spent 3 hours of time with. It's not sustainable. So I had to pivot to a cash only practice. So a lot of people who do good insomnia work may be cash pay, or insurance may not cover seeing that provider. So find the people in your area, figure out if anybody takes insurance. If you're close to an academic center, typically you can send patients there. That's a great step. And then also there's now these digital cognitive behavioral therapy apps for insomnia, and I think that those are really fantastic. And I've been encouraging the American Academy of Sleep Medicine to do a review of the different apps just so that we have a comprehensive list. I have my own comprehensive list that I'm happy to send to people if they're interested, because there are lots of very good ones, and I don't want to endorse a specific product, but I'm happy if people want to reach out to me, I can tell them which ones I would recommend at this point in time. But those can be a really great starting point. And there's really nothing to lose, right? So say this patient who you're trying med after med after med, nothing's working, just say, hey, try this app and see what happens. And even if they're really severe, you never know. Some people, even with really severe insomnia, respond really well to these app-based treatments. I had one woman in my own practice who, before I saw her, she was really complicated. She had insomnia, hypersomnia, she was on stimulants, sedatives. This person you would never think would respond to an app for insomnia, but she had somehow gotten put in a research study on an app for insomnia. I don't know how this happened because she should have been excluded, but she wasn't, and she responded really well. And yes, I had to work with her after, it had to be paired with face-to-face, but I was able to get her off of both the stimulant and the sedative, get her sleep a lot more stable. She's somebody who needs regular follow-up. I continue to see her quarterly to kind of keep her on track, but nevertheless, the app was a fantastic starting point, maybe more effective than I could have been. I don't know, because I might have gotten sucked into, thinking about all these other issues and not done the straightforward version, which she actually responded really well to. So the app, you have to give the caveat and say, this may or may not work, but let's go ahead and try it. But really for anybody, you can just kind of have them try it and see what happens. As long as you do want to still follow up with them, you can make sure you're reinforcing what the app does, or, giving some additional guidance and making sure they have a good outcome. Yeah.
Great. Yeah, no, that's really helpful. And so we'll put your contact information, like your practice information and stuff, in the video description, so if people want to reach out and learn more. So we'll put that there. And the apps are great because they also give patient support between sessions.
Yeah.
Right? So it's something that's tangible for them. They can go in there, they can get support, they can get psychoeducation around their sleep.
Right.
And so it's a really nice adjunct to the one-on-one work.
Yeah.
And the data shows that these apps
are quite effective.
Yeah.
And I do, I've personally tried a couple of them where I've gone through. One of them, it was you check in daily, or I think a few of them, right? So every day I'm going into this thing and watching the content. I don't know if you've done that too. Mm-hmm. But yeah, it's great. And I think, and some of them even pair you with a coach.
Yes.
So I think that's, ideal. And then if they're paired with a coach and you see them once a month, once every 2 months, as the clinician, it's a really powerful combination.
Yeah. Great.
Yeah.
So let's talk a little bit about lifestyle medicine.
Yeah.
First of all, for anyone who's not familiar with it, what is lifestyle medicine? And then what's the intersection of that with sleep?
Yeah, great. So lifestyle medicine is a newer medical subspecialty. I think it's been around for 10, 12 years now, or around about that. And what I think of it is the science of healthy lifestyles. So it is it's a very evidence-based specialty. That's one of the number one goals in lifestyle medicine, is that you look at the research. What you are recommending has to be based in research, but it is the science of what constitutes a healthy lifestyle. And then once we know what is a healthy lifestyle, how do you help people implement that on an individual level and on a societal level, which of course is going to be the most important. And when you think about what constitutes a healthy lifestyle medicine breaks it down into 6 pillars, it's called. And so you have nutrition, right? Exercise, not surprisingly. Sleep is a pillar, yay. Meaningful social connection is one. Avoidance of risky substances, and then stress management, dealing with past trauma, that kind of thing. And so the framework of lifestyle medicine is that a lot of 80% of chronic health conditions are caused by derangements of one of these pillars, one or more of the pillars, and that if you can kind of tee up all of these 6 pillars, you are going to help the person be healthy and happy for as long as possible. You're going to give them the longest health span possible, and that it doesn't mean that somebody who has nobody can ever have perfect 6 pillars, right? But in this magical world, magical patient has perfect lifestyle. It doesn't mean they can't get pneumonia, or they can't get COVID, or they can't get cancer. Of course they can, but if you tee up these pillars, they will fare better. They'll respond better to chemotherapy. They'll respond better to the infection, right? Their outcomes are going to be better. Yes, they could still, anybody can die of the wrong infection, but they're going to fare better than if the pillars were out of whack. And so it's this really helpful framework where you kind of have these tangible areas to focus on with your clients, and it's great that it's backed by the evidence. So from a dietary perspective, I know it's not just eat more vegetables and exercise, right? It's like I can give very tangible recommendations, like this is what I want you to do with your diet, and here's how I'm going to help you do it. And you get, as part of the training for lifestyle medicine, you get some coaching trainings and motivational interviewing, techniques to try to help people make smart goals, and then you also figure out how to implement it in your practice. So for me, I outsource the coaching to another company. I just pair people with a coach who is trained in lifestyle medicine through a third party, and they work with the client. I also check in with them, right, and reinforce the messages, and maybe make little tweaks depending on, work with the coach, work with the patient to kind of achieve what I'm looking for. But it's really helpful. I don't have to do everything myself.
Great. Yeah. No, it's such a great comprehensive approach, right? Because we were just talking about CBT-i, cognitive behavioral therapy for insomnia.
Yeah.
But that's just one piece.
Yeah.
And there's all these other pieces, like you were just talking about, like
Right.
social connection and exercise and nutrition. So how does that all fit into, like, if you're working with a patient who has sleep issues, like, how do you bring all of that in?
Right. So I did the sleep training, especially behavioral sleep medicine training, right? Cognitive behavioral therapy for insomnia. And then I did this lifestyle training, and that was the big question, right? Like, how do I bring the two together, right? What do I want to do? And so I just decided to use lifestyle medicine as a tool to treat sleep and wake disorders, founded my practice, Lifestyle Sleep. And so we just take a comprehensive look at the person's life, everything they do in their life and what's going on with their sleep, and try to tee up these pillars while we're also working on the sleep, and see if we can get them to be as healthy and happy for as long as possible. And in sleep medicine, we see insomnia and hypersomnia and the more kind of psychological sleep issues, if you will, but you also see a lot of obstructive sleep apnea, which is highly associated with obesity and overweight and just poor lifestyle factors overall. It would be one of these chronic diseases where 80% of it, is due to lifestyle factors. So I was aware early on in my sleep medicine training that, like, I can give those people a CPAP machine, and that's great. I should give them a CPAP machine, but the CPAP machine is not doing anything to address the underlying cause of the sleep apnea. And I thought thought from day one, the best thing is for me to address the underlying cause. And in a simplistic level, it's obesity, so I'm going to address their obesity. So all throughout my early sleep medicine practice and my fellowship, I would give people weight loss counseling to try to treat their sleep apnea. But now with this lifestyle training, I realize, it's a lot more complicated than that. Our standard weight loss advice, unfortunately, doesn't work. So I wasn't giving bad advice and I was helping them, but now I'm doing a much better job of that. So part of in lifestyle medicine is not just insomnia, but it is in lifestyle sleep, it's treating obstructive sleep apnea, helping people to that's really where a lot of these lifestyle changes make a big impact. So a lot of people who have particularly mild sleep apnea, they're just a little bit overweight, they have poor dietary quality, having them work with one of these nutritionists. I have them do myofunctional therapy, which are strengthening exercises, physical therapy for the throat that can help to improve the muscle tone and reduce snoring and sleep apnea. Stop alcohol, at least for a time, that will improve snoring. We kind of do all of these factors which are treating the underlying cause of the sleep apnea. If the sleep apnea is more severe, I may want them on a CPAP, at least initially, while they work on all of this. I don't want to leave them untreated. But then the goal is to implement all of this stuff and eventually potentially wean off the CPAP or have a lower pressure on the CPAP, or at least just help them feel as good as they can possibly feel.
Mm-hmm. Yeah, no, it's great. And what I hope people kind of are hearing through this conversation is that sleep issues are highly treatable.
Yeah. Right?
Because often, like we were discussing at the beginning, we'll go cycle through meds or different kinds of patients not tolerating CPAP or whatever, and it can feel very hopeless again for the clinician and for the patient. Yeah. But there's so many things that can be done.
Yeah.
And they don't have to be complicated things.
Right.
Simple changes can make a big difference.
Absolutely, yes. And I realized, I love helping people with their sleep. The more complicated the insomnia at this point, the more excited I am to see this person, right? And sometimes even I'll get this referral and I'm like, oh no, there's so much going on, right? But then I think, this is what I want, right? Like, this is interesting. If I just see really simple patients, you get bored over time. So I love seeing these people, but other clinicians, they don't have the same training, they don't have the same experience. It's really overwhelming for them. How would they know what to do with the client? And so sending that person to a particularly behavioral sleep medicine expert, they're going to just be able to conceptualize the case in a way that somebody without their training won't be able to do. And like you said, it's often something really simple. Like the most common offender is people just spending too long in bed. Mm-hmm. We know that. And so reducing their time in bed has a huge impact. However, you're not going to be able, it can take a lot of convincing to get the people to agree to that. So that's where kind of the art comes in and getting buy-in and, sort of gently helping them figure out that they need to change their sleep schedule. But it's incredibly powerful once you implement that change. And I mean, that's number one easiest change that you can have people do if they're having insomnia, is just to spend less time in bed.
Yes. Yeah, such a great point. And in fact, so that's sleep restriction, and that's been shown to be effective as a standalone component of CBT-i, even if you can't do a full CBT-i protocol.
Right.
I think the name is really not helpful because...
Right. So we moved away from it. So it was sleep restriction, and then sleep compression.
Yes.
And now the latest term that people are using is sleep efficiency training.
Yes.
So, So that's where kind of the spin, the buy-in comes in. You tell somebody you're going to sleep restrict them. That doesn't really sound very helpful. You say, I'm going to help your sleep be more efficient. Maybe there's a little bit more buy-in. Or what's the other one? Sleep consolidation therapy. There's different ways to say it. So it's all about how you talk about it to them, how you explain it to them to get them to make that first step. And sometimes also they're not willing to make any change to their sleep schedule, or you start where they're willing, right? So the wake time, I think, is the most important aspect of sleep health, actually, having a regular wake time. Biologically, humans always did. We had so many environmental cues that we just woke up at the same time regularly. Now as those cues are peeled away, we have our blackout shades, our temperature control, we don't have any noise in our bedroom, we don't have any social contact in our bedroom, those cues are pulled away one after another, and so we can have these really unnatural, irregular sleep schedules. So I think the key to fixing people's sleep problem is usually starting with the wake time. But again, you have to get the buy-in. So I usually start just wherever the patient is willing, right? If they're willing to start by spending a little bit more time outdoors or eating more plants or just relaxing in bed or getting out of bed and reading, you just kind of have to meet them where they are, and then you can work up to what you need. And I remember there was this one client who was spending like 9 hours in bed, sleep was really fragmented, and I just could not convince him. He needed to spend 7 hours in bed to get his sleep on track, and I could not convince him. And it took us like 8 sessions. And finally, at the end of the 8th session, he was like, oh, so all I need to do is spend 7 hours in bed? I was like, yeah. And he's like, well, why didn't you tell me? Oh, you did tell me that. He like went back and he was like, this is what you've been telling me the whole time. But the point is that it took a long time, but he got there eventually, and the sleep improved, and and everybody has to get there on their own time. And sometimes it's they see me. If we get stuck, I send them to somebody else. They come back to see me. People sometimes need to hear things different ways from different people to get the end result.
Yeah, absolutely. Yeah, and it's really that personalized approach, right?
Yeah.
Seeing what that person is willing to do, what's important to them, what are their goals, what are they hoping to achieve, how much time do they think this is going to take?
Yeah.
Because sometimes people think it's going to happen overnight, and that's not necessarily the case. Sometimes it is the
sometimes
case.
It is.
Sometimes
I
it is,
know.
but not
Yeah,
always.
it's amazing.
Yeah.
But mostly it's not. It's a process.
Yes.
Yeah.
So you gave an amazing talk inside my clinical sleep kit program, which I have for clinicians to learn about sleep medicine, if you're a non-sleep doctor. And you spoke about hypersomnias.
Yeah.
And one of which is excessive daytime sleepiness, and maybe you could speak about what a hypersomnia is for anyone who's not familiar. But one of the things you talked about was the Rise Up protocol, which I think is great because any clinician can start implementing that with their patients. So maybe could you share what is the hypersomnia and then what is the Rise Up protocol? Yeah,
great. So hypersomnia, it just means, being too sleepy. And there's kind of 2 issues that somebody could have in being too sleepy is kind of non-specific. So they could either be sleeping too much during the night, right? They need 12 hours of sleep in a night to feel rested, or they could be too sleepy during the day, which one of those causes could just be not getting enough sleep at night. And they can have just one or both of those issues. So somebody who has excessive sleep time or is too sleepy during the day, you would say they have a hypersomnia. They are too sleepy. Whether it meets clinical criteria or not is a different question, but from a practice standpoint, doesn't necessarily matter. And then this Rise Up protocol is just a way to help people get more activated earlier in the morning. So even just this week, I had somebody who said that they woke up feeling non-refreshed. They had to hit the snooze a bunch of times. This was actually somebody I was seeing for sleep apnea, but I recommended that she, in addition to the sleep apnea treatment that we were doing, that she implement the Rise Up protocol. And I said, I think you can pretty easily, shift your sleep schedule. The sleep schedule wasn't very extreme. It was just a little bit later than she wanted. And I said, I think you can pretty easily shift it just by implementing this protocol. So Rise Up is a protocol that was developed by a wonderful psychologist, Kate Kaplan, who's in the Bay Area. I think maybe you've met her. And she did it, I think, as part of her PhD project. And there's been a little bit of research published on it. It's an acronym, and so you just go through the acronym. Like with this patient, I literally just pull it up, I go through the acronym, and then I find a way for them to implement these elements. And it helps them wake up a little faster. So the R is refrain from snoozing, which doesn't necessarily mean don't hit the snooze button, but it means pick a wake up time and get up at that wake up time. So this particular person I saw earlier in the week, they liked hitting the snooze button. And I said, that's fine, but just choose your end time for the snooze, right? And that's the start of the refrain from snoozing, right? So say 8:30 or whatever. So you get up at 8:30 every single day, you get out of the bed. And then the I is increase activity. So you kind of get moving right away. You can move around the house, doing chores or preparing things, or ideally maybe you go for a walk, a brief walk, jump rope outside, something like that. The RIS. The S is shower or splash water on your face and hands. Getting in the shower is pretty activating. If you don't want to do a whole shower because that's difficult, or you don't like showering every day, cold water splashed on the face or hands can also be kind of a wake-up cue and help us vasoconstrict our vessels. That moves more blood to the brain and can help us wake up a little faster. E, exposure to sunlight, so get ideally outdoors and get some sunlight. If you can't, just opening up the window shades. Even if people are in a pretty dark place, just turning on the lights as bright as possible, maybe using an artificial bright light therapy lamp or one of these Zoom rings like you have here is going to be helpful. RISE, RISE. U is upbeat music. Just the upbeat music is more about having something positive and engaging that you do in the morning. So, a song that you're looking forward to, a podcast that you really like. A lot of people who have difficulty getting up in the morning, it's because they dread their day, they dread their morning. There's nothing to look forward to. So why would they want to get up and start the day when it's just going to be such a drag, right? It's just much easier to remain in bed. And when you start talking to these people, you will figure out more and more how true that is. So if you can give them something positive to look forward to, what do you enjoy? Let's put that in your morning routine. It can really help motivate them to get started. And then the P is phone a friend, which is just doing something social in the morning. And that, of all of the pillars, the lifestyle pillars, you would think that diet would be the most important. Diet is really important. I'm not saying it's not. That is like huge. But of all of the lifestyle medicine pillars, social is actually probably the most powerful. When you look at longevity, the people who live the longest tend to have meaningful social connections. They tend to have a sense of purpose, some reason to go on. And we know that even people who are quite ill, right, if they have all these really strong social connections, they have a project that they're working on, like they'll just kind of go on and on and on and on. And maybe they even code, they come back, right? Like you see these people. It's really powerful. And from a sleep perspective, it is also probably actually the most powerful cue of all of these aspects of the Rise Up protocol. So what I always tell people, like what I told this person this week, is if you can find an activity that is outdoors, has movement, and is social, that's kind of like the golden way to help yourself wake up faster. So maybe it could be a walking group in your neighborhood. Maybe you go for a walk and call a family member, maybe with a dog or a pet. Maybe you like pickleball. You schedule pickleball every single day. The thing is, you have to do these things really 7 days a week, especially starting out, to have it work. So if, say it's something like pickleball, you're really going to have that scheduled like at least 5 days a week, and then maybe the other 3 days you're going to go for the walk, or the other 2 days you're going to go for the walk and talk to a friend. But something outdoors, social, and movement related is the ideal way to start your day if you're having difficulty waking up. And you'd be surprised, people who do this, they'll say, oh my gosh, I never thought that I was going to be a morning person, and now I'm a morning person. It's incredibly powerful. But without the social component, I'd never hear that, actually. If they only do the exercise and the bright light, interestingly, it helps them wake up faster, but it's not the same magical effect as if you can add in the social. So that's one thing I'd like to do eventually with my practice, Lifestyle Sleep, is have more of these opportunities so I can tell people they don't have to figure out what to do to get that movement and social and outdoor time. I say, here's where you're coming, you're coming with me, right? I'm going to take you, and we're going to all go hike together, and we're all going to wake up and feel connected and start our days in a better way.
That's amazing. Let me know when you start doing that.
I know. Yeah, it's hard because the people with hypersomnia are not as socially engaged because they're sleeping all the time. So it's hard to find these people. It's hard to reach out to these people. That's why if you have these people, send them my way. And the more they can be connected with each other, right? The ideal is the hypersomnia morning group just goes, right? I don't have to be there every single day. There's enough people who they are motivated. I can send a new patient that I see who has, who I think would benefit. I can send them to the group. Maybe they walk at 10, right? They're not walking at 6 a.m. or something like that. The more you can connect people who suffer from hypersomnia, it's actually really helpful.
Yes, it's such a powerful thing to just be with people who understand as well. It's like hypersomnia is one of these invisible conditions that isn't often taken seriously. People think, oh, you're just being lazy, you're tired all the time.
And because we all sleep, we all think we're experts in sleep, right? So I understand how to manipulate my sleep, but I know that the things that I personally do, some of them are going to work for other people, but not everything that I do. I have one phenotype of sleep, and it's not going to apply to people with different phenotypes. So I think with hypersomnia, people assume, well, I sleep, and this works for me, right? So why doesn't it work for you, right? But they're not you. They have a totally different sleep phenotype. They have different things going on. So yes, it's really hard for people to understand if they're not suffering from it themselves.
Yeah, absolutely.
Yeah.
So let's talk a little bit about hypersomnia testing, because this question comes up a lot about SSRIs and other REM suppressing drugs, because maybe you can explain why that's relevant to hypersomnia testing, what an MSLT is, and then so the question that comes up a lot is, okay, I have this patient on Prozac or some other REM suppressant, and I think they have a hypersomnia. I want to send them for a sleep study, but the sleep clinic told me they need to go off all their antidepressants, and that's not safe for that patient to do. So how would you advise the doctor in this scenario?
Yeah, so the MSLT, multiple sleep latency test, it is a napping test that was actually developed to enable clinicians to diagnose, it's called type 1 narcolepsy. Type 1 narcolepsy is a very specific type of hypersomnia that is an autoimmune condition. It's an attack on the hypocretin or orexin producing cells in the brainstem. Those cells get destroyed, and so you do not make, when you have type 1 narcolepsy, you do not make orexin, which is a neurotransmitter that is important for sleep-wake continuity, for maintaining wakefulness during the day and maintaining sleep at night. In particular, it has a lot of effects on the REM sleep system. So what happens when you have no orexin is that REM becomes dysregulated, and you have intrusion of rapid eye movement sleep, of REM sleep into the day, which gives you muscle weakness. That's part of REM sleep. And then you have at night, the REM sleep is supposed to happen at the end of every 90-minute sleep cycle. It will happen at the wrong time. So you might go right from wakefulness into REM sleep, which is not normal. You're supposed to pass through these other stages of sleep. So the sleep-wake system is destabilized. And the multiple sleep latency test, this napping test, is really good at picking up on that, because what will happen is you have the subject who's coming in for testing, they take 5 naps during the day, and you try to see if they fall asleep, and then if they do fall asleep, do they go into REM sleep right away? And when you have no orexin, you do go into REM sleep right away. And so it's very good at picking up type 1 narcolepsy. Most people who have type 1 narcolepsy have an abnormal MSLT test. However, those REM suppressing medications, SSRIs, they can suppress REM sleep a little bit, or they can actually have some orexin-like effects on the REM, where maybe you're not going to go into REM sleep on the napping test, so they can give you a false negative result. However, type 1 narcolepsy is a very small portion of the population. I give the prevalence in the other video that you referenced. I think it's like, 0.5% or less, right? It's very uncommon. So chances are the patient that you are seeing, and there's these other things, there's the cataplexy, the loss of muscle tone. So really, for type 1 narcolepsy, clinically, you should pretty much be able to make that diagnosis without the multiple sleep latency test. The SSRI medications do suppress cataplexy, this muscle weakness, so you would have to get the history that, before they were on the medication, they had cataplexy, maybe they don't have it anymore, but with the right questions, you should be able to get at that. There is a very small chance that if you do a good clinical history, you won't be able to tell that it's narcolepsy type 1. So basically what I'm saying is you don't really need the MSLT. And it turns out that the MSLT for conditions other than narcolepsy, type 1, is a terrible test. It has horrible test-retest reliability. There's huge confounders. It depends how much, if the person is a shift worker, it's not going to be accurate. If the person is sleep deprived, it's not going to be accurate. These medications affecting, it's basically a useless test, and some normal portion of the population has a positive MSLT. So it is sensitive for type 1 narcolepsy, but it is not specific at all. So those people who truly study hypersomnia disorders basically all universally think that the MSLT should disappear. So since I started my practice, my private practice, my current practice, Lifestyle Sleep, is this cash pay practice, but before that, I was at a facility that we had a sleep lab. I could have done all the MSLTs that I wanted to do. There were no barriers to getting it. Have I ever done an MSLT in my clinical practice? Never. The answer is never. Because when I see a patient, did I see people with hypersomnia? That was the obvious next question. Yes, all the time, right? That's a common disorder that we see. But when I saw a patient with hypersomnia, with a good clinical history, I could figure out what the cause of their hypersomnia was, and it was never anything that I needed an MSLT to be able to diagnose. So you actually don't need to use the MSLT. The only reason for the MSLT nowadays is to get insurance authorization for stimulant medications if you are prescribing them for the indication of narcolepsy. You may have to get that. We are going to be moving away from those requirements, but as you know, it takes a long time to change insurance regulations. So there is a circumstance under which you may have to do that test. And what I would say is just do the test on their medications. Just say, let's just do it on the medications and see what it shows, right? And you may get the result that you're looking for to prescribe the medications. If you don't get that result, you could consider weaning. But again, do they have type 1 narcolepsy? No, they don't. I mean, so basically you're just trying to get an off-label justification for a stimulant medication, and is there any other way that you can do that, is what I would say. As I personally have a non-pharmacologic practice, so I do not prescribe stimulant medications. I help people get off of stimulant medications. I do not prescribe sleeping medications. I can, and I do prescribe them to help people get off of them, but my goal is always to use these lifestyle and behavioral strategies to treat hypersomnia. So I'm not running into, admittedly, I'm not running into these insurance issues. I've never had to get an MSLT to justify prescribing a stimulant because I'm not prescribing any stimulants. Yeah. But I don't know if that answers the question.
So helpful. Yeah, that was so helpful. Thank you for explaining all of that.
Yeah.
And we've kind of talked as well about stimulants in hypersomnia and kind of, the efficacy of those. And I think we've had similar experiences in terms of patients maybe not really feeling that great on the stimulant medication when they have hypersomnia, or feeling like they're over-caffeinated, like this kind of jittery feeling, but they're not really getting better.
Yeah.
Can you speak to that a little bit?
Yeah, so I think, I have this non-drug practice, and that's always my goal. I tend to take a very, strong view about medications, like let's try to do it without medications, right? I was really inspired by this first insomnia experience that I had, right, where this patient with really severe insomnia just got better instantly with, one session of CBT-i. Again, that's not always the case, but I was so inspired by it that I was like, let's be low tech. Let's be as low tech as possible, right? Lifestyle medicine as well. Like I'm prescribing fruits and vegetables and exercise and social connection and, changing your sleep schedule and changing the way you think about sleep. That is what I'm doing. But I know not everybody has time for that, right? I live in the real world, and stimulants can be a useful tool. And also, I'm not saying that no patients are helped by stimulants. They can be useful for some patients. Some patients don't have side effects, and they do find it helpful. However, the stimulant medication is asymptomatic. It's always just going to be a symptomatic treatment. It is not addressing the underlying cause of the hypersomnia. Even in type 1 narcolepsy, where you have a total lack of orexin, if you're giving a stimulant, it's acting on the dopamine system, or maybe a little bit of serotonin or norepinephrine effects. It's not acting on orexin, right? So you are not treating the underlying cause of the problem. And stimulants over time, people develop tolerance to them. They can develop dependence on them. It can have all of those issues. But I think, from a practical standpoint, I think the question is are the patient's symptoms resolved? Are they? I would just encourage you to follow them long term and see how they're doing on the medication. And like you said, if it's not fixing all of their problems because it's not addressing the underlying cause, maybe we can take a more comprehensive look at some of these other factors that are contributing to the hypersomnia, help them with that, and maybe even wean them off of the medication in the long term, if it's something that they want to do.
Great. Thank you so much. And so I think as we wind down, what tips do you have for non-sleep physicians and therapists that they can use in their clinical practice?
Yeah, so the first thing I would say is do not tell your patients that they need to get good sleep and that they need to get 8 hours of sleep per night. The 8-hour sleep myth has been dispelled. It basically was based on data done in college campuses on college students and recent college graduates in the early days of sleep research. They found that, if you took college students and you gave them 8-9 hours in bed per night, their academic performance went up, their sports performance improved, all of that. And that is very true in the college age population. But it turns out that the amount of sleep we need actually declines throughout our life. And so somebody who's in their 40s actually doesn't need 8 hours of sleep per night. And even the American Academy of Sleep medicine has recommendations for how much sleep people at different ages need, and for the oldest age, I believe it's 7 to 8 hours, but that's actually not even a sleep recommendation. It is a sleep opportunity recommendation. Those guidelines were developed before the days of Fitbit, where you know how much sleep you're getting. The Fitbit is not that accurate, or Apple Watch or whatever, but you see when you look at your sleep tracker data, oh, I spent 8 hours in bed, but I only got 6.5 or 7 hours of sleep. That's actually completely normal. Sleep isn't 100% efficient. So we have to view those guidelines, the 7 to 9 hours of sleep per night for healthy adults, as sleep opportunity per night, not actual time asleep. There can be some wakefulness in those 7 hours. So I think that sleep is really important, and it is important to ask your patients how they're sleeping, and if they say they're not sleeping well, to maybe get a little bit more information if you can, or send them to a sleep specialist. But don't just say if they're not sleeping well, they're not getting enough sleep. Don't just say you need to get more sleep, because the reason they're not getting enough sleep may not be that they don't have the sleep opportunity. It may just be that they're stressed, or they have other factors, or they're not exercising, or they have other factors that are contributing to that poor sleep duration. So as primary care physicians, we can actually do a lot of harm by putting this goal in the patient's mind of 8 hours of uninterrupted sleep as the only acceptable way that sleep can look, when in reality that may just be totally unachievable for them. It's like telling them you have to look like Cindy Crawford, or whoever the latest supermodels are. Right? Cindy Crawford was a long time ago, but they're not. There's no way they're ever going to be able to achieve that. So give people a more realistic expectation of sleep, rather than just this idea that they have to have this uninterrupted perfect sleep every single night. Sleep is variable. It's normal to wake up a couple times during the night. It's normal to take a little time to transition into sleep. Maybe wake up a little early, have some thoughts. That all can be perfectly normal. And I think we don't do enough education as a sleep community about what normal sleep does look like. So how would primary care providers know? But I would say just don't give that message. You can say, okay, your sleep bothers you. What's going on? Why does it bother you? If you don't know if that's normal or not, that's fine. We don't expect you to know if it's normal or not. We'll try to have more education about that in the future, but just send them to a sleep clinic. Send them to a sleep medicine professional, ideally a behavioral sleep medicine provider who can help them improve their sleep. And then this message of sleep regularity is another one that actually we used to give the message, right, with the promise of sleep. The most important aspect of sleep health was duration, how much sleep we're getting. But now we know that that's actually just one aspect of sleep health, and another probably more important aspect is actually that regularity of sleep. And I think in particular, the wake time, having a really regular wake time. So patients, when they are having sleep difficulties, they will spend extra time in bed to try to make up for the poor quality sleep, right? They had a really bad night. Normally they would get up at 6, but I'm just going to turn off the alarm and sleep till 8 because I had such a terrible night. But when they do that, they're weakening their circadian rhythm, they are weakening their sleep drive, and it's actually just making the problem worse. So if you can have patients who have sleep issues get up at the same time every morning, you have to choose a reasonable time for them. If they've been getting up at 2 p.m., don't tell them to get up at 8 a.m., right? If they've been getting up at 2 p.m., maybe we do 1 p.m., or their ranges, maybe their range of wake times is 12 to 3 or something, and so maybe you choose 2. You have to kind of look at that, personalize it. But if they can get up at that same time every day and do any of the Rise Up protocol, implement any of that, go for something social, outdoors, and active, then that is going to be also super helpful for anybody with sleep problems, be it insomnia or hypersomnia or just difficulty waking up in the morning. Regular wake time, get outdoors, social, active. Yeah, so that would be it.
Fantastic. Thank you so much. This is so helpful. There's so much information that you share that's really tangible. So where can people find out more about you? Where is your practice? And we'll put all the links in the video description, but can you tell us your website address and more about your practice?
Yeah, so my website is lifestylesleep.io. I don't know why we chose IO. We thought it sounded cool. It's going to change eventually to .clinic, but right now, lifestylesleep.io. I'm Michelle Jonelis. I also have a website, michellejonelismd.com. lifestyleSleep.com, I believe, which does direct you to the Lifestyle Sleep website as well. So you can search for me, you can search for my practice. I am based here in Marin County. Like I said, I do have an office space that's in Mill Valley where I can see people in person. I also do Zoom visits as well for people that are further or just prefer Zoom. Either one is fine. And if you want to refer a patient to me, you can just email me. Actually, my work email is michelle@lifestylesleep.io. michelle@lifestylesleep.io, and I'm happy to answer questions, guide, if they can't see me because they can't cash pay or whatever, to guide you to an appropriate provider who can help care for your patients, or just answer questions about sleep, or come talk to your group about sleep. I'm available for all of those things. And would love to, like I said, I love talking about sleep. I love helping people with their sleep. So not everybody does. So, if you don't like doing that, I'll help you out. Yeah.
Great, amazing. Well, thank you so much. And I'm so grateful that you were able to come over and we were able to connect in person and do this. I think we might have to do another one of these, because I feel like even though we covered so much information, we just kind of scratched the surface. There's so much more to talk about.
There's so much there. Yeah, so much there.
Yes. But thank you so much. Check out Dr. Michelle's website. And again, all the links will be underneath. And then, I'd love to do this again.
Sounds good. Yeah, you have a lovely house, lovely view, and we're getting lots of bright light. We're not outdoors. We were talking about that, but maybe next time.
Next time. Yeah, we'll get the right microphone and set up.
Yeah. But we're social. We're kind of moving, a little. Yeah. Anyhow, thank you.
This YouTube channel is for you, the physician, the clinician who wants to learn more about clinical sleep medicine, because most of us don't get that much training in clinical sleep, but all of our patients have to sleep. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine.